your stare ahead.
Ow, ow.
Hey guys, I'm Summer, I'm a KG12, and this is my topic for case talk for you. So let's start off with the case. We have a 3-year-old male presenting to your ER after running into a wall. No, see? Yeah, now it's right? Vital signs are within normal limits. Physical exam is unremarkable except for that. Nice big laceration. So every year we see about 7 million patients in the emergency room that seek care for lacerations, and about 2 million of them occur in the pediatric population. So this is obviously a procedure that we do quite frequently. But for some reason, this procedure is associated with a lot of mythical and dogmatic teachings. And I think a lot of that has to do with the fact that we're concerned about infections. We're concerned that things are going to get infected, which is a legitimate concern. But if you really think about it, clean wounds rarely get infected, right? We only see a fraction of lacerations in our ER, because most people just treat them at home, right? You get a cut at home, you're just going to wash it with some soap and water and clean it with a paper towel, right? You're not going to dress it sterilely or any of that. And so, do we really need to address this boy's wound in a sterile fashion in the ER? We'll kind of answer that question at the end of our presentation. So let's take a look at some of the evidence behind this procedure. These are our objectives. We're going to talk about wound irrigation. We'll talk about the choice of gloves for the procedure. We'll talk about using glue versus suture repair. We'll discuss the use of absorbable versus non-absorbable sutures. And we'll also talk about whether or not we need to suture all lacerations. And this talk only applies to simple, clean, uncomplicated lacerations. So no bite wounds, we're not going to apply this to dirty wounds, or wounds involving like foreign bodies, or wounds involving fractures, or wounds in high tension regions such as over any joint lines, or wounds in the hands or feet. So let's talk a little bit about wound irrigation, which is an important part of this procedure. Here we have 4 different types of cleansing solutions. We have normal saline, sterile water, chlorhexidine, and an iodine-based solution. So which of these is the ideal cleansing agent for irrigation?
Neither.
Tap water.
Wow, did you guys like see my presentation? Yeah, so first of all, studies show that the antiseptics on the bottom don't really reduce the rate of infections. They're actually for external use only, and some studies actually suggest that using these in open wounds can damage cells and delay the process. I know some people like to mix the iodine and the bottom of normal saline in areas that way, but that's actually not a great idea. So it really comes down to normal saline or sterile water versus tap water for irrigation. And there's actually a Cochrane review that took a look at water for irrigation. And there was 11 trials. Most of them were like quasi-randomized trials, and 3 of them were actually randomized controlled trials. 7 of them compared the rate of infections and wound healing with the use of water versus normal saline. 3 actually took a look at cleaning versus not cleaning lacerations at all. Shocking, I know, right? Because we're all used to irrigating all of our lacerations because we're concerned about infections. But these trials made that comparison. And 1 trial looked at the use of procaine spirit versus water, and we're not really going to talk about that. It's not really relevant for us. Procaine spirit is used for episiotomy wounds. And by water, they took a look at tap water, cool boiled water, and distilled water. So let's sort of dive right in. The first analysis was tap water versus no cleansing at all. There were 3 trials that took a look at this comparison, and these were actually surgical wounds. So some of these patients were allowed to shower themselves and bathe their wounds, and a group of patients were not allowed to bathe their wounds. And the primary outcome was infection rates, and secondary outcomes were wound healing and patient satisfaction. And the numbers are up there for you guys to take a look at. For primary outcomes, there was no statistically significant difference for infection rates between the 2 groups. Secondary outcomes, there was no, again, difference in the incidence of difference in the wound healing or rates of wound dehiscence between the 2 groups. And there was no objective measurement for patient satisfaction, but patients who were allowed to shower themselves reported a sense of well-being because they were allowed to shower. The second comparison took a look at the use of tap water versus normal saline. This involved 6 trials, and they took a look at both acute and chronic wounds in adults and children. And again, the numbers are up there for you guys to take a look at. There was no statistically significant difference in the rates of infections in either acute or chronic wounds in adults or children with the use of tap water irrigation or normal saline. And again, we're talking about simple, clean lacerations. Secondary outcomes, again, no change in wound healing between the 2 groups. For cost analysis, let's just say we can save a lot of money by using tap water, right? Because we're not wasting money with the normal saline bottles and the syringes and the kidney basins and the splash parts. So you can save a lot of money by using tap water. And the third comparison was water versus normal saline. So they took a look at cooled boiled water and distilled water versus normal saline irrigation. And there's no significant differences between the 2 groups. And there were no secondary outcomes reported for this particular analysis. There was another study that specifically took a look at children, and they compared the use of tap water versus normal saline. These patients were randomly allocated to either groups, and they followed up in the ED 48 to 72 hours later for wound checks. And there was no difference in the infection rates between the 2 groups, again, for clean, simple laceration. So these studies suggest that tap water might be just as good as normal saline for irrigating clean, simple lacerations. I mean, it's cheap, it's abundant, it's easy to use, it takes less time, right? You can just walk your patient over to the sink, have them run their laceration under the water, and actually walk away, see another patient, and then come back, and you're ready to repair your wound. If you think about it, there's less of a biohazard risk to you as a healthcare provider, right? Because you're not sitting there or standing there with stuff splashing all around you, right? So that's another consideration. As far as water pressure, the pressure in most water faucets exceeds the pressure, that's the recommended pressure for wound irrigation with a syringe. So if you're concerned about removing like foreign objects or bacterial colonies, that's not really a concern because you have good pressure in the water faucet. And it might reduce anxiety levels in children, right? I mean, sticking a big syringe in their face, it's not really ideal, and this might be more beneficial. What about for these lacerations? So going back to our boy, he doesn't have a scalp laceration, that's somebody else. But what about these lacerations? Do we need to even clean them? Can we just start suturing them after that application? I mean, lacerations in the face and the scalp, those 2 regions are highly vascularized and less prone to infection than other parts of the body. So do we really need to torture the kids? I mean, it's kind of like, they might feel like they're being waterboarded, right? I mean, they can become very anxious and highly cooperative, or even more anxious and uncooperative than they normally are. So do we even have to irrigate these simple, clean lacerations? There's a study that was actually done in the 90s at Stony Brook that took a look at the incidence of wound infections and wounds that were irrigated versus not irrigated in the face and the scalp. And they found no statistically significant difference for the wound infections between the 2 groups. I realize this might be a little controversial because, again, we cleaned everything because we're afraid of infections, but this is what the study showed. And there was no difference in cosmetic appearance either between the 2 groups. Any questions so far? Since we were on the topic of scalp lacerations, I wanted to point out a cool method of repairing these lacerations that I actually just learned about. We're used to stapling these lacerations, and some places suture these lacerations. But there's a technique called the hair apposition technique. Anyone know about this? So what you can actually do is take a couple strands of hair on either side of the lacerations, and using forceps, just kind of cross them over and make a single twist, and secure it with a drop of glue. And you fix your laceration. Here's a more close-up picture, and the bottom picture is kind of cool because you're removing the hair out of the view with some tape. There was a study that was actually done out of Singapore that took a look at this method. They compared this method with suture repair, and they took a look at lacerations less than 10 centimeters. And the results showed that this technique had less scarring, fewer complications, lower pain scores. It was obviously shorter in terms of procedure time and led to less wound breakdown. And this method actually became their method of choice for repairing scalp lacerations. Does anyone do this at county or downstate? All right, on to the next topic of discussion. What about glove selection? So do we need to use sterile gloves for all of our lac repairs? I know they feel better than the regular gloves, but do you really need to use them? No? No, right? We don't really need to use sterile gloves for all of our lacerations. And again, we're concerned about infections, but there was a study, a randomized control trial done in 2004, and they took a look at patients greater than a year old, so adults and peds patients, and they compared the infection rates. Patients the use of sterile gloves and clean gloves, and again, no statistically significant difference between the rate of infections. So we can save a lot of money just by using clean gloves. Do we need to suture repair all of our lacerations? The answer is no. So we can actually use tissue adhesives for that as well. And these are best used on like short, linear lacerations, non-gaping wounds that you can easily oppose. They're not really good for wounds in high tension regions, so wounds overlying joint lines or wounds on the hands or the feet. And you shouldn't use them on wounds in mucosal surfaces either. But they're really great, especially for peds patients, because one, it's less painful, and two, you can save them a follow-up visit, right?
Sarah, I don't suppose you saw anything about hardware store super glue versus Dermabond, did you?
Yeah.
Okay. I've always wondered.
No. I'm just going to talk about you can try it out and let me know.
Oh, I have it. It works.
Well, there's a Cochrane review that there's a Cochrane review that took a look at the comparison of tissue adhesives versus sutures. There were 13 trials, 11 of which made this comparison, and the other two just compared different types of tissue adhesives. And they were looking at procedure time, cosmetic outcomes, and pain scores. And the results showed that there was no difference in cosmetic outcomes between the two groups. Pain score and procedure time favored the use of tissue adhesives for repair. There was a small but clinically significant risk for wound dehiscence in the glue group. I think the number needed to harm was 40. And there was a difference with respect to erythema, which actually favored the use of glue. So we can definitely use glue for lac repair. And there's some studies that I put up here that took a look at the use of glue versus sutures in pediatric patients. For the first trial, children actually followed up about 3 months later, and they were evaluated by 2 different plastic surgeons who were blinded to the method of closure. So they didn't know if it was suture repair or glue repair. And they concluded that there was no difference in cosmetic outcomes between the 2 groups. And the study also concluded that the use of glue is faster and less painful than traditional suture repair for those type of facial lacerations. The second study was similar to the first study, except it looked at lacerations everywhere in the body except lacerations on the eyelids, those in mucosal surfaces, and those overlying tension regions. And they came up with basically the same conclusions. There was no difference in cosmetic outcomes. There was a longer follow-up period for the second study. The children actually followed up at 3 months as well as 12 months, and they followed up with a plastic surgeon who was blinded to the method of repair as well. And there was no difference in outcomes between the 2 groups. And finally, the third study was actually an adult study that took a look at the use of Dermabond versus suture repair. And they found, again, no difference in cosmetic outcomes at 3 months. And they concluded that it's faster and less painful method of repair as well.
Sarah, just 1 second. This slide is actually really interesting. If you look at the length of each wound that they're talking about from their studies. Usually, when I'm thinking about gluing a wound, it's kind of intuitive to not glue a wound that's 4 cm length. But there's that study in the third that goes any length, and there's one that's 5 cm. So it makes you wonder if you know, as a provider, at least for me, if I should be using glue more often in wounds that are a little longer than that.
Good point. Does anyone glue lacerations that are up to 5 cm?
So I've done it on some really big, like 6 and 8 inch wounds, and the best way to do it is you'll bring the wound together in one spot, put a dotted glue, let it sort of dry, and then keep moving around and closing it. And then once you have many dots holding it together, then you can go over the whole and put a sheet of the glue on top of that, and it works pretty well. You get pretty good opposition that way. But you just have to do it systematically and break it down like as if you were doing sutures, so it comes back together straight.
How superficial were is this?
One was a neck wound that didn't go through the platysma, so it was pretty loose tissue and pretty superficial. One was on a back, so it wasn't a lot of tension and relatively superficial.
Next, we'll talk about absorbable versus non-absorbable sutures. Traditionally, we're always taught to use the non-absorbable, right? Because they're associated with better cosmetic outcomes and lower infection rates than their counterparts. They might not be the best choice for our pediatric patients, because then you subject them to a second visit, a follow-up visit, and that's more torture and anxiety for them. I mean, it might be more, scary for them to have suture removed than actually suture placement. So you might want to think twice about using sutures in this patient population. What did the study show? So I put up 2 studies up there that took a look at this comparison. They were actually both in pediatric patients. Fresh lacerations, again, simple, clean lacerations. And they found no difference in cosmetic outcomes, infection rates, the wound distance between the 2 groups. So we might want to think twice about using the non-absorbables. And finally, do all of our lacerations need sutures? And the answer to that is no. There's an interesting study that I put up here that took a look at suturing versus conservative management. So conservative management in this study meant tap water irrigation, followed by application of a polymix and B ointment, and sterile gauze, and follow-up. And the suture group had repair with monofilament sutures, and also application of polymix and B ointment, and gauze and follow-up. And results showed no difference in cosmetic appearance 3 months. Time to resume normal activities was the same for both groups. And obviously the patients that did not have suture repair reported less pain and shorter treatment time. And these were actually full thickness hand lacerations, less than 2 centimeters, that would normally require suture repair. I thought that was pretty interesting. So these are the takeaway points. Please use tap water for irrigation for simple, clean lacerations, especially for our PEDS patients. Obviously, take into consideration the nature of the wound and any comorbid conditions, and water should probably be of drinking quality. Clean gloves are fine. You don't need to use sterile gloves for all their lac repairs. And you can definitely glue non-gaping, simple lacerations. Please use absorbable sutures in our pediatric patients and don't torture them with a second follow-up visit. And you might not need to repair all lacerations, especially small ones. These are my references. A very special thank you to one of our awesome Penn Fellows, Dr. Safio and Dr. Chow, for helping me with this presentation. Any other questions? Are you guys going to do anything differently now?
I have a question. Were there any studies that looked at patient comfort with different irrigation solutions?
What do you mean? Well, I believe, let's go back to the studies. Oh, the only
Just the showering.
Oh, yeah, just the showering versus no showering. I don't think there was any objective, like comfort measurement or anything like that, the other studies. In the Cochrane review, I didn't.
Actually, the beta, you mentioned the betadine may be damaging to tissues?
Yeah, so some studies say that they might damage cells.
I mean, I know the chlorhexidine for sure.
So those are both actually recommended for external use.
Right. I know like ortho guys. it's
Yeah,
like-
and for, yeah.
So my highly scientific, non-blinded, and study with a police officer who fell and took a chunk out of his knee, and I don't remember what the circumstances were, but I needed to use both tap water and normal saline in it without any anesthesia. And with the normal saline, he was fine. With the tap water, he was in significant discomfort.
Oh, probably because it has significantly higher like water pressure.
No, it was there was no significant difference in the pressure. It was just because the saline is at there's less tissue damage. You're going to have some lysis, cell lysis with the tap water because it's a hypotonic solution.
Any questions?
How about those high pressure sprayer, these are nozzles? Sometimes I feel like they damage the tissue.
Yeah, so some studies